afternoon, everyone. I am Dr. Avichala Taxak, a consultant in peripheral vascular interventions at Medanta Hospital right now. I've been trained from AIMS New Delhi, and my primary expertise is in endovascular interventions or surgery, whatever you call it. We have an expert panel with us today who are radiation oncologists, and it is a very interesting panel where we are going to primarily focus on how radiation oncology has advanced in providing, expert and really personalized cancer care, where they can talk about all the advancements in the radiation therapy and how it integrates with other referring clinicians, and thereby reducing side effects and improving the quality of life in cancer patients. We have with us Dr. Khosa, Dr. Rajender Kumar, Dr. Hukku. So I would like to ask you firstly about firstly, I want you to discuss how do you define effective multidisciplinary care in your daily practice? What are the elements that make you successful apart from just talking about the patient and its, symptoms in a multidisciplinary meeting? Any of you who would like to answer this?
I think we start with Hukku, sir.
So, good afternoon. I think when Ms. Anchal ने वो शेयर सुनाया था कि सब कुछ जल गया, बचा क्या है, हम बच गए, जला क्या है, probably she was referring to radiation. Because, so, before I answer your question, the last line was, हम बच गए, जला क्या है. So, the modern radiation oncology is about that, कि वो जलाती नहीं है, बचाती है. Now, as you said, and as you have been listening since morning, that cancer is a multidisciplinary, the treatment is multidisciplinary. आज से कई सालों पहले, a few decades ago, when surgery was dominating, then the surgeons used to say that they will remove everything. And the best example is, in breast cancer, we used to call Halsted mastectomy, where the breast and, all the muscles around everything close by, everything was removed. Now, from that era, we have come to, breast conserving surgery, and that is possible only because, radiation has come for help, and chemotherapy and, other drugs have come to help. So, it is truly a multidisciplinary approach. Now, the patient is not aware. So, it is the duty of the treating team that whatever and whichever specialists are, part of the regimen, the case should be discussed. And that is what we call tumor boards, which happen in most of the institutions. But there are exceptions to that. And there are some institutions where tumor boards are not held for years. That is not the right policy because tumor board is a place where all the specialists can pool in their ideas and deliver the better care for the patient. So they are must. And the other thing is somebody, last week I was in a conference, one doctor coined a term which was called democratic tumor board. So I said, what is a democratic tumor board? She said that democratic tumor board is a board where all the three specialists have to speak. Nobody dominates over the other. And the last thing is that if tumor boards are held, religiously in institutions, who audits them? You take a decision in the tumor board that such and such thing should be done. After that, the patient goes to a particular specialist and, the treatment is changed. So, there should be audit if you have to deliver well in this multidisciplinary setup.
Would you like to add to it, Rajender?
So, Dr. Avichala, sir said everything about all three specialties. I would like to take an example for multidisciplinary care. For example, we are seeing a patient, new case of carcinoma breast. So, how things starts? First, we send them to the intervention radiologist who does the biopsy, goes to pathologist, and she says it is carcinoma breast. Then we need further test, immunohistochemistry. And finally, it comes to tumor board and we discuss whether to go for breast conservative surgery or complete removal. That too, whether we add chemotherapy first or surgery first. And suppose that happens, then the further plan about radiation, about managing side effects. So we need our rehabilitation team, physiotherapy team, nursing educator, pick line, and all those things. So it's actually multidisciplinary team, and how we manage it, it is like that only. So patient center में है, and everyone is helping her during this journey along with the financial things also.
So every step is important. All of the physicians, surgeon, oncologists, medical oncologists, everybody needs to be on board. So more personalized care is something which can give better outcomes. Dr. Khosa, can you elaborate about what is the role of radiation therapy and other parts of cancer care in organ preservation and organ saving therapies? That's what primarily.
As Dr. Hukku pointed out, it has been historically a surgeon-dominated branch where removal of an abnormal tissue of your body was the sole treatment which we had over centuries and last many decades and centuries. But then our expectations of the results keep on improving, so as the trials keep on improving and newer modalities keep on coming into picture. We conventionally we are used to surgery or medicines, but radiation is a branch. Probably if you say in medicine, this is one of the youngest branches, just 125 years old. But the evolution which has happened in the last years have been significant, and it has been remarkable in many of the tumors. Barring few blood related tumors where the role of radiation is very limited or in very select group, most of the other cancers, radiation has played a very important role. Now, what happens is, the specific to the question, how is it has improved. So whenever for a layman, whenever we remove a tumor or something, we only remove the part which is visible to a naked eye to a doctor, or something which he has visualized on a CT scan, on an MRI, which also have come in the last 20-25 years or so. But what he is taking out is just what is visible to a naked eye, and the resolution of a naked eye is very limited. Yes, they use microscopes in newer surgeries to see even the smallest of the lesions, but then there are some microscopic things which go beyond the normal vision of a doctor on the surgery table or in the radiology area. There is where the radiation comes into picture to kill those tumors. That was historically where it started. But then other areas where when we started seeing that the results of radiation added to the results of surgery alone, that means that these tumors are technically sensitive to radiation and may have a scope of going away with surgery in some of the cases, like your larynx, a voice box cancer, a very common symptom, prostate cancers, cervical cancers. So these are those very common cancers where after seeing that the results improved with radiation, slowly the organ preservation approaches took into picture. Just assume an example. You have a voice box and you have a tumor in the voice box, and you take out the voice box from there. What the patient is left, yes, he is alive, but lifelong he is without a voice. There are few modalities to bring in an artificial, but nothing can replace what is natural to you. So radiation gave the same results, 95% cure rates in CA vocal cords. So why should you go for a surgery? Prostate cancers, similar results to a prostatectomy. The side effect spectrum is a little different. You have to choose what suits you the best. Cervical cancers, a revolution which has come. Excellent results, excellent cure rates, women living a normal life after CA cervix, only radiation and chemotherapy treatments, no surgery. So there has been a shift. There has been a lot of research and development of this branch, and we have seen tumors are sensitive. We all know there is a DNA component, there is an abnormal molecular structure, and that is where the radiation strikes and brings on its results.
Thank you so much.
You know, there is one myth which is, which, you know, many patients, when they come to the clinic, they say, if the organ is removed, then why should the cancer come back? So, the message is that wherever you can preserve the organ, you should preserve it. It is not that if you remove the breast, if you choose mastectomy against breast conservation, mastectomy has a better results. You know, breast conservation has come because the results are similar. Same thing, you know, when they say prostate cancer, if you remove the prostate, then I will go for surgery because removal of prostate, the cancer, you know, the gland is out. Why should the cancer come back? But that is wrong. So organ preservation, wherever it is available, the patient should ask for that, and the results are excellent, as Robin said.
So based on which organ it is affected, which stage it is, organ preservation can actually improve the quality of life in a very extensive way. So
Preservation is only possible if you catch it in an early stage.
Exactly.
So there comes the role of prevention and early diagnosis.
So, sir, what do you think is the most common obstacle when it comes to early detection of cancer with respect to referring physicians and clinicians, and maybe about the imaging that is available at the moment?
You see, we just listened something about home care. Now, 70% or more than 70% healthcare in India, in oncology and other places, it is in the corporate setup. Rest is government. Now, prevention takes a back seat. Corporates are not interested in prevention. Government hospitals want to do prevention, but the lines are so long that they don't have time. At best, you have in corporate hospitals, you know, the executive health checkups, and you can go there and, you know, do certain tests for early diagnosis. But that is not what prevention is. You have to go in the society. You have to, you know, make the public aware that, you know, there are methods of prevention, and you have to spend a lot of money and a lot of manpower to go out and, you know, pick up early cancers from the society and educate people so that they come to the hospital for early diagnosis. But unfortunately, it is lacking. And if you look at the, you know, huge hospitals around the country, there is hardly any hospital which has a department of preventive oncology. If we prevent, you know, there are head and neck cancer is largely tobacco is a, you know, which is causing head and neck cancer, it is causing lung cancer apart from other things, and they are highly preventable cancer. The cervical cancer is highly preventable. Now we have a vaccine for that. But, you know, it is so surprising. Again, you know, I was in this medical conference last week, and the speaker was talking about preventive oncology, and he asked the women in this hall, raise your hands who have done a mammography till now. No, not here. In that meeting. And you'll be surprised, there are more than 50 women and only 2 hands went up. And they were all doctors. So prevention, if you do, probably that is the best thing, but it is left to NGOs, and they have limited resources. So there should be an emphasis on that. If you do that, probably in another 25 years, it will be a different scenario altogether.
Maybe if we put in more resources into creating more awareness about prevention and the steps towards when to seek medical care, that is how it may.
So, Dr. Avichala, I would like to take 30 seconds only. Sir
Sure.
has said everything. So, जैसे हम लोग बहुत सारी पॉलिसीज में कहते हैं कि गांव को गोद ले लो, एरिया को गोद ले लो. हमारे जो कैंसर सर्वाइवर्स है, वो जिस कम्युनिटी से आते हैं, वहां हमें कैंसर कैंप करके हेल्थ टॉक देनी चाहिए. हमें बेसिक टेस्ट बताने चाहिए कि देखिए आप मैमोग्राफी, सीरम पीएसए, CA-125 और एक अल्ट्रासाउंड आप करा लीजिए. हमारे जो आशा वर्कर्स है, गायनी में बहुत उनका रोल रहा कि पहले डिलीवरीज घर पे हुआ करती थी और अब वो हॉस्पिटल्स में होने लगी. तो आशा वर्कर्स, रूट केयर वर्कर्स, टीचर्स, रिटायर्ड हेल्थ प्रोफेशनल्स, उनको आपको जोड़ना चाहिए. मैं बड़ौत एरिया से बिलोंग करता हूं. मेरा होम टाउन, मेरी बेसिक एजुकेशन वहां से हुई. तो मैं वहां हर सैटरडे जाता हूं. आई एम गोइंग सिंस 2013. तो वहां लोगों से मिलना, कभी कबड्डी मैच कराया, कभी कुछ कराया, और उस बीच में आप धीरे से उन्हें एजुकेट करो. तो हमें वहां जाना होगा, क्योंकि सर का कहना सही है कि अगर आप कॉर्पोरेट्स में बैठे हैं और वहां बात करो प्रिवेंटिव की, तो वो हम यहां बोल सकते हैं स्टेज पे, बट वो मैसेज वहां तक नहीं जाएगा जहां से वो लोग निकल के आते हैं. मोस्ट कॉमन हेड नेक कैंसर एंड सर्विक्स कैंसर कम्स फ्रॉम रूरल एरियाज. So we have to reach there and we have to educate people there.
So, is there a way we can make these cancer treatments more affordable in private hospitals?
So once you go to the community, you will face this question. This is the biggest question. And sir knows it. Whenever we talk any toxicity, we always talk about financial toxicity. Avichala. So like I'm going to my OPDs to my rural areas, and obviously वहां बहुत भीड़ है कैंसर पेशेंट्स की. हर हफ्ते 20-30 पेशेंट आपके पास आएगा. वो मोस्टली सेकंड ओपिनियन के लिए आएगा, और जैसे ही उसको पता चलेगा कि आप मैक्स हॉस्पिटल में हो, आप अपोलो में हो, आप बड़े हॉस्पिटल में हो, वो कहेगा डॉक्टर साहब मैक्स नहीं आ सकते. तो उसके लिए तरीके हैं. आप अपने यहां एक टीम बनाइए, 1 या 2 लोगों की, जो उसकी फाइनेंशियल काउंसलिंग करेंगे. बहुत सारे एनजीओज हैं. प्राइम मिनिस्टर रिलीफ फंड कहता है कि आप अपने ट्रीटमेंट का 50% और मैक्सिमम 3 लाख रुपीस आप ले सकते हो. आप उसमें पीएम रिलीफ फंड में अप्लाई करिए. सीएम रिलीफ फंड देता है, हर स्टेट का सीएम रिलीफ फंड है, 3, 4, 5 लाख रुपीस दे देगा. बहुत सारे हमारे अच्छे एनजीओज हैं जहां अगर प्रॉपर एप्लीकेशन जाए तो 2, 3, 4, 5 लाख रुपया वहां से सपोर्ट हो सकता है. तो ये आपकी जो डेस्क है ना कैंसर की, वहां एक व्यक्ति जरूर हो जो इस चीज के लिए एजुकेट करें. और मुझे लगता है अगर 8, 10, 12 लाख रुपए आप अरेंज कर लेते हो, तो कोई भी पेशेंट, रूरल बैकग्राउंड का भी व्यक्ति आपके बड़े हॉस्पिटल में ट्रीटमेंट करा सकता है, बशर्ते आप उसे गारंटी दे कि ब्रेस्ट सर्जरी में इतना लगेगा, रेडिएशन में इतना लगेगा और कीमो में इतना पैसा लगेगा. तो वो बहुत जरूरी है, एंड दैट इज ए बिगेस्ट चैलेंज. आई थिंक सर विल एग्री टू मी.
You know, I will tell you the other side of the story. I have been an entrepreneur. Now, of course, I have one center with me. Earlier, it was a big corporate center which I was running at BLK. For 10 years, I ran that center. Now, what I did was that for 5 years, I did not raise the charge for radiation. It remained fixed from 2009 to 2014. What happens in hospitals is that on 1st April or 1st May or 1st June, without asking the treating team, the management raises 10%. So in 5 years, you see how much it goes. Other thing which we did, because I could, that belonged to me, I could do that. Brachytherapy is a machine where, cervical cancer and other cancers, you have the source going inside and, so you have 2 patients or 3 patients in a day. Now, that machine has a source which is decaying over a period of time. After 3 months, you have to change. So if I treat 2 patients or if I treat 10 patients on that machine, the cost doesn't come to me except doctor's fee and all. So what I did as an entrepreneur was that I requested my colleagues in Safdarjung Hospital, Maulana Azad Hospital, where that machine did not exist, to send their patients. And we were charging 25,000 rupees for a procedure for the regular people. For these patients, we offered it for 2,000 rupees. If I could do that as an entrepreneur, why can't, the others do? So these are certain things which, because the treatment is going, very, very expensive. And many times in a corporate hospital, if you request the management for concession, the answer, what the answer comes? Doctor, you leave your fees. Let the hospital charges come. Now the doctor's fees is minuscule. Even if I lose, say, I don't, it doesn't help the patient. So there are ways to do that. And if we do that, probably many of our, the other example, a big hospital registered for CGHS. There is a treatment called image guided radiotherapy. From CGHS patients, you charge 1,80,000 rupees. But from the regular patients, you charge 3 lakhs. If you can deliver IGRT in 1,80,000, why are you not charging 1,80,000 from rest of the people? Why are you charging 3 lakhs? So these are things, but the society is very different. I'll tell you one more small thing. When I started entrepreneurship in 2009, in my board, I said, when the mobile companies are, mushrooming, the charges of, phone calls and data is going down. So when the radiotherapy centers are coming, why shouldn't we keep our rates down? I can give, if others are charging for IMRT 1,25,000, I'll charge 1 lakh or 75,000. You know what answer I got? Doctor, don't do that. In North India, if you don't charge what others are charging, the word will go around that this center has second-hand machines. They don't have good machines. So that is why they are charging less. So, somebody has to come and change the scene.
That's an incredible entrepreneur journey that you told us about. I mean, yeah, corporate culture is something that we all have experienced and can't do much about it. So, other than that, there are these new technologies that we hear, the IGRT, the intensity modulated therapies, stereotactic therapy. How do they reduce the toxicity? And just briefly, if you can tell people about what is the role?
I think sir started with this Jal Gaya ya Bach Gaya. So that was the ancient, the 25 years back if you go. And when I was also in my medical college, we only had cobalt machines and all. So the treatment was intended for a particular part of your body. But inadvertently, the adjacent areas, some even far off, would have got huge amount of radiations. And what it resulted, yes, it may have cured the patient, but a lifelong quality compromise because of their excess radiations would always remain in the patient. And this was the problem with the general public also not accepting radiation, not preferring radiation for their treatments. But as the development and linear accelerators came into, we have the modalities of IMRTs, VMATs. So what these do is, these are all software-based calculations which we do. We basically guide computers that this is the only area which we need to treat while the rest needs to be protected. So it does all sorts of software calculations, inverse planning, keeping this in mind. Just like what is AI right now, you give it instructions and it will give out just the specific answer for that. So the radiation started 20 years back. We want this thing, and the inverse planning started. It made a plan where the radiation was only concentrated to the tumor and the surrounding organs received much lesser doses. The softwares kept on improving, and the technology has raised to a level that there is very, very sharp difference in the doses that we are able to deliver now from the tumor to the adjacent. I can quote you an example of your prostate or a cervix. See how close it's to your rectum or your urinary bladder. And still, after completing your entire radiation, the chances of these toxicities in these organs are significantly reduced when we use these new technologies of IGRTs and VMATs and IMRTs. What IGRT in addition has done, it has given you a sense of confirmation before you treat a patient. It's not that you have planned something and you have delivered something, but yes, you confirm before you deliver it. And last, you talked about SBRTs. This is a new spectrum which has opened up nowadays. What we normally say is, this tumor is radiosensitive, this is not radiosensitive. So radiosensitivity has nothing to do. There is now concept is there is nothing called sensitivity. Just increase the dose of a particular radiation and it will become sensitive. So that is how more and more tumors are now getting amenable to complete cures by using different types of technologies we do.
So Avichala एक एग्जांपल दे दूं, थोड़ा सा मजाक है, अब खत्म भी हो रहा है सर. इंडिया गया पाकिस्तान में और हिट कराया जाके उनके बिल्कुल सेलेक्टेड एरियाज, बिल्कुल कॉलोनी के बीच में एक एरिया था कि जी यहाँ ट्रेनिंग होती है, वहां हिट कर दिया. सो इट इज लेजर गाइडेड बॉम्बिंग. So now we as a radiation oncologist, we are doing laser guided radiation. So we are hitting delicate areas inside body with very high accuracy. जैसा इजराइल ने कतर में किया.
So Lastly, I wanted to talk about what if there is any role in palliative therapy, if there is a role of radiation in palliative therapy. If any of you would like to talk about that.
अविचला ये सबसे ज़्यादा नेग्लेक्टेड हमारे ब्रांच में सबसे ज़्यादा नेग्लेक्टेड स्टेज है कैंसर की, बाय द फैमिली, बाय द पेशेंट एंड बाय द डॉक्टर. जब भी किसी का स्टेज 4 होता है और काफ़ी ज़्यादा डिसीज फैल जाती है और हम किसी भी ट्रीटमेंट की बात करते हैं जो उसकी क्वालिटी ऑफ लाइफ को ठीक कर सकता है, तो क्वेश्चन आता है अब जिंदगी बची ही कितनी है. सो पैलिएटिव केयर इज वेरी इंपॉर्टेंट. और डॉक्टर हुक्कू सर से, डॉक्टर आनंद सर से हमने यही सीखा है, पैलिएट का मतलब ये नहीं कि जो आज दिख रहा है उसे पैलिएट करो. पैलिएशन का मतलब है कि अगर कोई प्रॉब्लम आज से 3 महीने बाद आने वाली है, ब्रेन मेट्स है, सिम्टम नहीं है, आज ही ट्रीट कर दो ताकि उसको कल क्वालिटी ऑफ लाइफ डिटेरियोरेट ना हो. नॉट बाय द ट्रीटमेंट बट वो ब्रेन मेट्स करेगा. कोई स्पाइनल कॉर्ड में, कोई फीमर में ऐसा लीजन है जो आज आपको बहुत पेन नहीं कर रहा बट आपने पेट पे देख लिया, वो कल फ्रैक्चर करेगा, वो कॉर्ड को कोलैप्स करेगा. सो पैलिएशन इज बेसिकली प्रिवेंशन ऑफ मेजर कॉम्प्लिकेशंस एंड दैट शुड बी वेरी इंपॉर्टेंट बिकॉज अगर कोई व्यक्ति कैंसर से जाना भी है बट जाने से पहले उसकी जो लाइफ है दैट शुड बी ए वेरी गुड एंड ही और शी शुड लिव विद ए डिग्निटी. सो पैलिएशन शुड बी वेरी एग्रेसिव.
Comfortable grade 4 cancer patients, a comfortable life is something that can be targeted and achieved. Thank you so much. अब मुझे इशारे आ रहे हैं organizers की तरफ से to end the session. Thank you so much for participating in it. Thank you to the panelists for their insights and thoughts.